Спасибо за приглашение. К сожалению, мой русский не очень хороший, and therefore I hope that you forgive me if I continue in English. The interpreters with me? My name is Christian Virchow and I come from the University of Rostock in Germany. I'm also editor-in-chief of Respiratory Medicine and the vice president of the European Academy of Allergy and Clinical Immunology. And I'd like to thank the organizers very much for inviting me, first of all, to this wonderful city, secondly, to this very interesting conference. Now, the first question you may have is, where the hell is Rostock? It does not work very well. No, this is the next. Okay, good. It's an old port city on the Baltic Sea, and I always show this picture because the university is down here, but this is where my students are. And it's located in the north of Germany, Berlin, Hamburg, Frankfurt, Munich, and north here is Copenhagen. And Kiev is somewhere there. Now let's consider an optimal inhalation, because this is what we as pulmonologists and allergists and general practitioners have to work with. And the gold standard is the inhalation of oxygen, and it has an evolutionary design. Because the device is the respiratory tract, and the device, the respiratory tract, is designed to fit environmental conditions, which is the atmosphere. So the challenge to inhalation therapy is we need to design a device and a drug which fits the respiratory tract. And inhalation therapy can be at best as good as a physiological inhalation. There's no way around this. Okay, well, what kind of medications do we have? And we have to consider, why do we do inhalation therapy? And we do inhalation therapy because the two drugs we inhale have an effect and side effect profile which, if taken systemically, are unacceptable long term because the side effects are too severe. And that's the only reason why we have to inhale. The challenges to inhalation therapy, however, is that most patients use inhalers not very good. And the more devices we use, the more errors occur. If we use different devices, patients make more errors. Even if you look at the compliance with patients who have asthma and severe asthma, the problem is that the coordinated inhalation and actuation is difficult for many patients with the pressurized meter dose inhalers. And there are many mistakes that patients make during inhalation, which in part are due to the devices we use. So let's consider a little bit, how can we do an optimal inhalation? We would have a patient who has disease, who has complaints. Okay? Now this patient comes to see you or me, and in order to do this, the patient has to be motivated and educated. And then we decide we would like to give the patient medication. And we decide that we would like to give controller or reliever drugs or both. And there's a relative large number of those on the market, but there's not much difference between fluticasone and beclomethasone and budesonide. They're all basically the same. It's much more important how we deliver it to the patient. And this is where the device comes in. And the device then should fit the patient, and we have possibilities to individualize the treatment by medication and by device. And hopefully we can motivate and educate the patient, and then we will have hopefully less complaints. But the important thing is, the only thing we can really work on as physicians is the device and the education motivation by teaching the patient. Now, many years ago, we came up, my old boss, Henry Mattes, great physician, with an idea, a flowchart, how to prescribe aerosol therapy. And first of all, we said, hopefully, all medications from one device, if possible. And we want only aerosol devices which do not contain fluorinated fluorocarbons, because this is not good for the atmosphere. Ukraine is a very long language. Yeah? I think my phone bill, my wife's phone bill, would be much higher if she would speak Ukrainian. It would take her even longer. Okay, but the next question is, can the patient perform an inspiratory vital capacity maneuver? If the patient cannot perform this, we need to inhale from a nebulizer or from a pressurized meter dose inhaler with a spacer which needs to have a valve, otherwise it doesn't work. But that's a big machine. Most patients, however, can perform an inspiratory vital capacity maneuver, and for those patients we need either dry powder inhalers or pressurized meter dose inhalers, plus minus a spacer. Now, the advantages and disadvantages of pressurized meter dose inhalers and dry powder inhalers are very familiar to you, and I don't have to explain this again. The big advantage of the dry powder inhalers is that they are breath actuated. If the patient does not inhale, no drug is released, which is a problem with the pressurized meter dose inhalers where coordination is required. The disadvantage here is we still have too many different devices. Some are better, some are not so good. Now, if we would think of an optimal device, the best device that we could think, it should be easy to use. It should be intuitive, like it should explain, you don't have to read 20 pages of manual. It should be, by looking at it, you should understand how it works. Just like a good software from a computer. Just look at it and you think, oh, this is how it works. You don't want to read or learn. It should give feedback to the patient. And we don't want spacers because patients don't use them. They are good, but nobody uses them, at least not in my country. And the inhaler should have a rapid effect, which of course depends on the medication that we use. So we have this idea that you should divide devices into so-called most forgiving devices. That the ideal device is a most forgiving device. I'd be very interested to know what most forgiving device means in Ukraine. But a most forgiving device is one which does not allow any crucial errors. And a crucial error is an error where no drug is being delivered, just as the lady in Dr. House movie did. Yeah, that's a crucial error. Because it would result in treatment failure. And it should have few, if any, minor errors, because a minor error results in insufficient drug delivery. But if the patient takes more doses, this can be overcome by using more doses. And we decided that we should have 3 questions basically. Which device has the desired drug? And is affordable for the patient? It's no use if a very expensive drug would be good for the patient, but he cannot pay for it. And I understand this is a particular problem still in Ukraine. Next important point, who will teach the patient how to inhale correctly? Will you do this, or the assistant, or the pharmacist, or hopefully all 3? And the third thing, do you have a preference for a certain inhaler? And I think the sort of important answer, or the important point is that an old drug, a working drug in a good inhaler is most likely better than a new drug in a bad inhaler. Now, what can go wrong with inhalation therapy? This is just a study, some years ago by Graham Crompton, who is also a member of the ADMIT group, and he showed that many patients make errors which are very problematic with pressurized metered-dose inhalers. They fire the device too early, they inhale too early, and so on and so on. Some inhale through, press here, but inhale through the nose, and many things which are difficult. I think I'll skip this for time reasons, but I think it is also important to understand that inhalation is very crucial. From a pressurized metered-dose inhaler, you have to inhale very slow and long. Whereas from a dry powder inhaler, you have to inhale very quick and very fast. And this affects the drug release. Because you can see here, this is the drug which reaches the lung, about this amount of drug reaches the lung from a turbohaler. If the patient inhales like this. However, if the patient inhales slowly and starts with, yeah, you can see that the pieces, the particles released are much bigger and have no possibility to reach the lung. So inhalation technique is very important. So again, from a pressurized metered-dose inhaler, slowly for about 5 seconds, and dry powder inhaler, fast and vigorously. That's very important take-home message. And can we overcome the problem of this flow-dependent release? And the idea is that the medication should only be released after a threshold inspiratory flow is reached. So if the patient does not inhale fast enough, no drug is released, only if the inhalation is fast enough. Okay. I'll go back, and the device that I want to introduce to you, because I understand it is new in Ukraine, we have it for many years, and I have been involved in the design of this device, is the so-called Novolizer. And the 3 points I would like to point out, that it is a breath-activated multi-dose inhaler which gives 3 feedback mechanisms to the patient. So the patient has 3 possibilities to understand if he inhaled correctly. One is optical, one is acoustic, and one is sensory. Optical is the green thing here. If the patient presses the lever back here, the medication is loaded into the device, and this window turns to green. If the patient then inhales, the window turns to red again. And there's a click when it goes back to red, and the patient has a little tape of the tongue. Just like with many other inhalations. This is the sensory part. But the inhaler is only activated if the threshold inspiratory flow of 35 liters is reached. You can take it apart if you want, because the good thing is this does not have to be thrown away like with the turbohaler and the discus. This can be reused, and only this contains the medication with a dose counter here. And this is the medication which you throw away and you put in a new one. Which is one reason why I understand it can be sold a bit cheaper than other inhalers. But let me highlight this very important point again, which I think is the most important one. The breath actuation is only possible when a minimal airflow of 35 to 50 liters per minute, which are necessary for disimpaction of the drug to be able to reach the lung, is achieved. This is highlighted here. It doesn't, of course, makes no sense at all. Nobody would inhale like this. But you see, here's the threshold, and the drug release only occurs when the threshold flow is reached. So if the patient doesn't inhale correctly, the indicator window does not turn to red and there's no medication being delivered. Drug deposition is good. You can see this here, very good deposition compared to other dry powder inhalers. But I just show this. And there's many randomized, double-blind, placebo-controlled studies where, for instance, the budesonide from the nebulizer is compared with the budesonide from the turbohaler. And to make a long story short, in these controlled studies, the results were absolutely equal. There was no difference. You can see here, no difference. You can see here, no difference in the reduction in salbutamol puffs. But the patients, when treated with the device, reported quite a large degree of satisfaction. You can see here that all patients said that the optical, the green turning red, was very good. The acoustic, many patients liked. Sensory, many patients liked. The overdose preventions, some patients said they didn't understand it, but most patients said, I was happy with the device when I used it in everyday practice. And this was duplicated by a good clinical response, as you can see, that this is the patients who went into the studies. About 10% had severe cough, moderate cough, mild cough, and after study treatment here, this was 3,000 patients, was markedly reduced. Only mild cough and moderate cough in few patients remained. Wheezing was significantly reduced. Diurnal dyspnea was reduced. Nocturnal dyspnea was reduced. And dyspnea on exercise-induced asthma was also reduced. Few words quickly about safety. Because in my country, I don't know how this is in Ukraine, there are too many people who inhale beta-2 agonists regularly or even in high doses when they don't need it. And the problem is that it's very clear that unbalanced high-dose beta-agonist treatment actually relieves bronchospasm acutely, but on the long term deteriorates asthma control. And that's why corticosteroids are so extremely important. And this plays especially a role, apparently, in children. This is an analysis from the Food and Drug Administration of the United States. We don't have to buy everything that the United States do. Yeah? But they found out that the risk of having asthma-related death, intubation, or hospitalization especially in children 4 to 11 years and 12 to 17 years, was lower when they did not receive beta agonists. And patients who received long-acting beta-2 agonists had a higher risk ending up in this group. This data can be discussed extensively. I just put it up there to highlight that patients who do not have bronchial obstructions or obstruction don't need a beta-2 agonist. And especially they don't need it regularly, like many patients do in fixed-dose combinations. So the FDA recommendations, 2010 here, was that long-acting beta agonists should be used for the shortest duration of time required to achieve asthma control, as we've heard from the previous speaker, and should be discontinued, stepped down, as we heard, if possible, once asthma control is achieved. And patients should then be maintained on an asthma controller medication only. And I think this is very important. This is very important in terms of safety. So the optimal inhalation now, we have a competent physician, which is you, who is educated and motivated by going to meetings like this. We have an appropriate treatment algorithm. We know how to treat patients, controller and reliever as shortly as possible, but controller long term. We have controller and reliever. We understand differential therapy. We understand particle size. But even more important, we look for the appropriate, for the most forgiving device. And then we hopefully have an adherent patient, because the patient then also understands what he or she is doing. And we of course need to educate and motivate the patient. And by this we will prevent complaints, and everybody's happy. So in summary, the Novolizers, in my opinion, offers a number of technical features which improve compliance, which can improve compliance, safety and efficacy, and hopefully costs. Although I don't know how much it costs in Ukraine. I understand that at the moment it's only available with budesonide in Ukraine, but you can put any other drug in this cartridge and inhale from it, and therefore it's an ideal device for patients with asthma and COPD. And you can read all this in a very important publication. You see why it's important? And the take-home message, Carnegie, is inhalation matters. It is very important. And devices are crucial for treatment success. And inhalation technique differs from a pressurized meter dose inhaler, inhale slow and long, from a dry powder inhaler, inhale hard and fast. And my fourth point is patients without airflow obstructions do not need beta-2 agonists, and therefore you need to reconsider fixed combinations, which are very important and very helpful to the more severe patients. But we often forget, in Germany at least, to step down these patients once they have achieved control. And with that, I thank you very much for your kind attention. As you know, I'm also the Vice President of the European Academy of Allergy and Clinical Immunology, and it would be my pleasure to see you all in Geneva in June next year. Dziękuję.